Hi, everyone. Okay. We're just going to wait a few minutes to start until everyone gets here. Hi, everyone. We'll get started in a few minutes. I'm just going to wait and see if anybody else wants to join. Hi, everyone. Thanks so much for coming to the CE. I think I'm going to get started. Looks like there's a lot of people in here. So thanks again for coming. So my name is Michelle Kolakowski. I'm one of the pharmacy residents. And today the CE is going to be called Tox Talk, Management of Drug Overdoses and Antidotes. So just a disclaimer, I have no financial interests or affiliations with any organizations. And if I use brand names, it's only for identification purposes only. So our objectives for tonight are going to be identify the methods of gastrointestinal decontamination, select the correct antidote given a patient case involving a drug overdose, match drug overdose symptoms to the most likely drug cause, identify indications for NAC therapy utilizing the Rumack-Matthew nomogram, and describe counseling points for patients to minimize the risk of accidental ingestion. So first, we're going to talk a little bit about the epidemiology of drug overdose and poisoning. So poisoning remains a common cause of morbidity and mortality in the United States. In 2018, the American Association of Poison Control Centers responded to 2.1 million poison exposures in the United States. This comes out to about one poison exposure reported every 15 seconds. So drug overdoses can be intentional or unintentional in nature. Some causes of unintentional drug overdoses include accidental ingestion of a drug, too much of a drug ingested, the wrong drug taken or given in error, and also accidental exposure of a drug through breast milk. It's not always the more commonly thought of cause, but it does contribute to drug overdose. Intentional drug overdose can be a result of intended self-harm. The majority of cases reported to the Poison Control Center were a result of unintentional exposure. So unintentional drug overdose is commonly seen in children and is usually accidental in nature and is associated with lower morbidity and mortality, while intentional drug overdose is more commonly seen in adults and has a higher morbidity and mortality rate. And I just want to comment on determining whether a drug overdose is intentional or unintentional in nature is not always a clear-cut situation. And it's important to approach each patient unbiasedly and look at the whole clinical picture before determining whether the drug overdose was intentional or unintentional. So patients at most risk for unintentional ingestion include pediatric patients, teens and adolescents, and the elderly population. Pediatric drug exposures often occur as a result of exploratory behavior, and in these cases, the amounts of drug ingested are usually small and the health effects are minimal. However, certain medications can result in serious illness or death, even in small amounts. These medications can be classified as one pill can kill medications in young children, and these include calcium channel blockers, tricyclic antidepressants, and opiates. So prescription and over-the-counter medications account for nearly 1/2 of the poisoning exposures reported in the United States. As shown in this chart from the Poison Control Center, the most common exposures reported include prescription and over-the-counter pain relievers, sedatives, hypnotics, and antipsychotic medications, as well as antidepressants. These medications are commonly available and often prescribed to patients, and this may contribute to the reason why we see these medications more commonly in overdose. So the Poison Control Center is a helpful resource for education and to provide recommendations in regards to patients presenting with a suspected or a confirmed overdose. The Poison Control Center employs many medical professionals, including nurses, doctors, and pharmacists who have specialized training in poisoning prevention and treatment. This service is available 24/7 to provide recommendations regarding ingestion of harmful substances. The phone number to poison control is 1-800-222-1222, which was intentionally made easy to remember in times of crisis. So now that we've discussed common causes of drug overdose and the overall prevalence within the United States, we're going to move on to discuss how to assess a patient presenting with a drug overdose and the initial steps of management. So patients that call the Poison Control Center can be triaged as deemed appropriate. So some patients can be managed at home with the assistance of the Poison Control Center or their physician's recommendations based on if they are asymptomatic, if they ingested a known non-toxic quantity of medication, and they are deemed a reliable source of information. However, patients that are symptomatic or those with uncertain exposure should be transferred to the emergency department immediately. So depending on the substance that was ingested, symptoms may vary from patient to patient, making it difficult to determine exactly what was ingested. Typically, patients will present with altered mental status, unstable vital signs, nausea, vomiting, and sometimes seizures. So it's important that a thorough history from the patient or a family member is obtained in these early stages of drug overdose. So any readily available information about the patient and the poisoning should be obtained, and this can include medication containers, pharmacy records, and any medication lists or any medications that the patient might have had access to prior to the drug overdose. So as I mentioned, obtaining a thorough history is very important in these early stages, and it's also important to physically inspect the patient to determine if they have any kind of transdermal patch, because many potentially toxic medications are now available in this formulation. So I'm thinking like analgesics like fentanyl, antidepressants, stimulants, and oftentimes this drug route is overlooked. So patients can get confused whether they have the patch on or if they took it off. And given that all these patches have different durations of wear and different indications, it's important to take a look and make sure that the patient doesn't have any kind of patch on as well. So as with any critically ill or injured patient, the first steps of management of an acute or chronic ingestion is to secure the airway, breathing, and circulation, also known as the ABCs. So patients presenting after an acute drug overdose are at an increased risk of aspiration pneumonia. These patients that develop aspiration pneumonia have a significantly increased mortality risk and an increased length of hospital stay. So after the patient's airway is secured and a thorough history has been obtained, the next steps to consider in a patient with drug overdose include gastrointestinal decontamination. So gastrointestinal decontamination refers to the practice of functionally removing an ingested toxin from the GI tract in order to decrease or prevent its absorption. So there are several methods that are used for gastrointestinal decontamination, but there is no conclusive data that has proven their effectiveness in improving patient outcomes. However, the decontamination method of choice recommended by the Poison Control Center is activated charcoal. Some of the other methods of gastrointestinal decontamination include gastric lavage, cathartics, and whole bowel irrigation. These other methods can be considered for an ingestion of medications that are poorly absorbed by activated charcoal and in other unique situations, which I'll get into when I discuss each individually. So first we have activated charcoal. So activated charcoal is a form of carbon that can bind other substances on its surface through adsorption. So adsorption is the adhesion of molecules to a surface. So essentially making activated charcoal involves heating carbon-rich materials to very high temperatures. And this activation process strips the charcoal of any previously absorbed molecules and frees up some bonding sites in the charcoal. So this process also reduces the size of the pores in the charcoal and makes more holes in each molecule, therefore increasing its overall surface area and available binding sites. So essentially how this works is the toxic substance attaches to the surface of the charcoal. And since the charcoal is not digested or absorbed by the GI tract, it stays in the GI tract and is eliminated when the patient has a bowel movement. The sooner the activated charcoal is given after an overdose, the better it works. The Poison Control Center recommends activated charcoal be given within 1 hour of ingestion. And basically, after 1 hour, the toxin has more than likely reached the small intestine, where the activated charcoal might not adsorb these toxins as effectively. And I just want to briefly mention that there are a lot of products now that are available over the counter that have activated charcoal. And these products include like toothpaste, facial cleansers, and it is also available as like a capsule form over the counter. And the over-the-counter activated charcoal differs significantly from the activated charcoal given inpatient. These over-the-counter products are not as activated, and therefore they might not be as effective. So the Poison Control Center recommends that these over-the-counter charcoal capsules are not routinely used for gastrointestinal decontamination. So there are some contraindications to the use of activated charcoal, and these include decreased level of consciousness or unprotected airways. And this goes back to that concept that I mentioned earlier about the risk of aspiration pneumonia. It's also contraindicated in patients that have an increased risk of gastrointestinal bleeding or perforation. Activated charcoal is a little harsh on the stomach, so you don't want to trigger a GI bleed or anything in a patient that might be susceptible. And it is contraindicated in ingestion of medications with a low affinity for binding with activated charcoal. So basically you can remember this mnemonic with the mnemonic PHAILS, PHAILS. So this includes pesticides, hydrocarbons, alcohols, iron, lithium, and other solvents. So basically these will not bind to activated charcoal as well. So the use doesn't have any benefit if you give activated charcoal if you're suspecting any of these as your toxin. So activated charcoal is typically given as a 25 to 50 gram one-time dose. However, multiple doses of activated charcoal can be considered. So multiple dose activated charcoal therapy involves repeated administration of oral activated charcoal to enhance elimination. So drugs with a prolonged elimination half-life and a small volume of distribution are particularly likely to have their elimination enhanced to a clinically significant degree by multiple doses of activated charcoal. So the Poison Control Center guidelines recommend the use of multiple dose activated charcoal therapy in life-threatening ingestions of carbamazepine, dapsone, phenobarbital, or theophylline. So the next method of gastrointestinal decontamination is gastric lavage. And gastric lavage has been used as a treatment for poisoned patients for many years. So how gastric lavage works is basically a tube is placed either in the nose or the mouth of the patient and goes into the stomach. And toxins are removed by flushing saline solutions into the stomach, followed by suctioning of the gastric contents. So basically you're going to put saline in and then aspirate the contents that are inside the stomach. So during the last few decades, there has been concern that complications associated with gastric lavage might outweigh the possible benefits to patients. And such complications of gastric lavage include pulmonary aspiration and mechanical injury to the GI tract. So next we have cathartics. So cathartics are another method of gastrointestinal decontamination, and they are intended to decrease the absorption of substances by accelerating expulsion from the GI tract. There are two general types of osmotic cathartics that are used in poisoned patients. So we have saccharide cathartics like sorbitol, and saline cathartics such as mag citrate, mag sulfate, and sodium sulfate. And since most drug absorption occurs in the upper GI tract, the use of cathartics is most likely to benefit patients who have ingested materials that are absorbed slowly, such as like extended release or delayed release products. However, cathartic use is associated with diarrhea, and when multiple doses of cathartics are given, significant free water loss and dehydration can occur. So some contraindications for cathartics include recent bowel surgery or intestinal obstruction or perforation, ingestion of a corrosive substance, because essentially you're going to be pushing that corrosive substance throughout the GI tract, which could cause more damage. If a patient has volume depletion or hypotension or severe electrolyte imbalance, and this is due to that free water loss and diarrhea that the patient would get, which could throw off electrolytes. And it's also recommended to use an extreme caution in patients that are very old and very young, in which the risk might outweigh the benefits. So I just want to briefly touch on ipecac syrup. So the use of ipecac syrup to induce vomiting after poisoning was a mainstay treatment, both at home and in the hospital. Ipecac syrup contains active compounds from plants that includes emmetine and cephaline, which cause emesis by local gastric irritation and stimulation of the chemoreceptor trigger zone of the brain. However, in 2003, the American Academy of Pediatrics recommended removing all ipecac from the home setting and recommended ipecac not be routinely used for pediatric poisonings. And the American Association of Clinical Toxicology also followed suit and concluded that there was no evidence from clinical studies that ipecac improves outcomes, and administration in the ED should be abandoned. So these recommendations stem from the risks associated with the use of ipecac syrup, which include Mallory-Weiss tears, which is essentially a tear of the tissue in the lower esophagus, which is most often caused by coughing or vomiting. It also has a risk of gastric rupture and aspiration pneumonia as well. And lastly, we have whole bowel irrigation. So whole bowel irrigation refers to the enteral administration of large amounts of an osmotically balanced polyethylene glycol electrolyte solution to induce a liquid stool and empty the bowel. So basically you give this orally or by nasogastric tube until the rectal effluent becomes clear. However, the recommendation from the American Academy of Clinical Toxicology is that whole bowel irrigation should not be routinely used in the management of poisoned patients. There is no conclusive evidence that whole bowel irrigation improves outcomes in these patients. So administration of polyethylene glycol solution can cause vomiting and abdominal distension that can lead to, again, aspiration and pulmonary complications. There may be a role for whole bowel irrigation in ingestions of sustained release or enteric-coated drugs that are not absorbed by activated charcoal. Or whole bowel irrigation can be used in patients that are presenting greater than 2 hours after drug ingestion, in which activated charcoal would not be recommended. So I just have a quick practice question. So within how many hours should activated charcoal be administered given an appropriate indication for use? A, yes, 1 hour. So after 1 hour, it's more than likely that the toxin has traveled to the lower GI tract and where activated charcoal might not bind as well to the toxin. All right, so now we're going to go into some of the most common drug overdoses and antidotes that are available to manage the overdose. So acetaminophen is one of the most commonly used analgesics in the United States and also the most common cause of liver failure. So toxicity is common primarily because the medication is so readily available and there is a common perception that the drug is very safe. Acetaminophen is available over the counter alone and in combination with numerous other drug products. So in patients that present with chronic acetaminophen toxicity, oftentimes the patients aren't aware that the multiple products that they're taking over the counter all contain acetaminophen. So it's important to counsel patients and make sure that they know what products they're taking and which products contain duplications of therapy. So like I mentioned, although acetaminophen does have a good safety profile at therapeutic levels, it can cause severe liver toxicity if taken in large amounts. So the maximum recommended daily dose is 4 grams per day. And if a patient takes 7.5 to 10, if an adult patient takes 7.5 to 10 grams dose, that is a minimum toxic dose for an adult. And the minimum toxic dose for a child is around 150 to 200 milligrams per kilogram per dose. So acetaminophen overdose can occur following an acute overdose or during repeated overdose. So an acute toxicity is the ingestion of a toxic amount of acetaminophen within a period of 8 hours or less. And a chronic toxicity is going to be ingestion of a toxic amount over a period of greater than 8 hours. So I'm going to go into a little bit about the mechanism of acetaminophen toxicity. So during acetaminophen metabolism, around 95% of acetaminophen is metabolized by phase 2 enzymes into non-toxic conjugates. However, around like 5 to 10% of acetaminophen is metabolized by P450 enzymes into a reactive toxic intermediate, which is known as N-acetyl-P-benzoquinoamine, or NAPQI, NAPQI. So in normal physiology, all of this NAPQI is conjugated by glutathione into a non-toxic metabolite and excreted. However, if intracellular glutathione stores are depleted or overwhelmed, in such a case like an overdose, where they can't handle the amount of acetaminophen or the toxic metabolites that's being produced, the NAPQI is going to bind to sulfhydryl groups on hepatic cells and lead to cellular apoptosis in early stages, and then later stages will lead to hepatic necrosis, which is irreversible liver damage. So here we have the Rumack-Matthew nomogram, and it's used to interpret serum acetaminophen concentrations in relation to the time since ingestion. This will help to decide whether or not the antidote N-acetylcysteine is indicated and therefore reduce potential hepatotoxicity to the patient. So to utilize this nomogram, you must know the number of hours post-ingestion, as well as this acetaminophen plasma concentration. So it's important to note that to use this nomogram, it can only be used for 4 hours post-ingestion or longer. So as you can see here, it just starts at 4 hours. So if a patient presents with within 1 or 2 hours, this nomogram might not be useful until they hit that 4-hour mark. So if the time of ingestion cannot be readily determined, which is very common in patients that are unconscious or patients that are have an altered mental status and can't directly tell you when the ingestion occurred, patients can be risk stratified with the use of this nomogram. So it's recommended to obtain a level and then treat the value if it falls above this treatment line. So essentially you would consider like the worst case scenario. So what is the earliest time the patient could have taken it and kind of assume the worst. And basically how this works is if when you plot the concentration and the time, if it's above this line, you would treat and give the antidote, the N-acetylcysteine. So as I mentioned, the antidote for acetaminophen overdose is N-acetylcysteine, or NAC for short. And essentially how NAC works is that it provides a cysteine group for glutathione synthesis. So basically it works on this portion of the metabolism. So it's going to give more glutathione so those stores don't become overwhelmed and they don't they go down this non-toxic pathway instead of going towards the toxic hepatocyte necrosis. So it's just repleting those glutathione stores that are overwhelmed or depleted. So NAC is available IV and PO. So the IV dosing regimen is a 21-hour regimen that includes a loading dose of 150 mg per kg infused over 1 hour, a second dose of 50 mg per kg infused over 4 hours, and a third dose of 100 mg per kg infused over 16 hours for that total 21-hour duration. And then the PO dosing regimen is a 72-hour regimen with a loading dose of 140 mg per kg, followed by a maintenance dose of 70 mg per kg every 4 hours for a total of around 18 doses. And it's important to note that with the PO dosing regimen, you have to repeat this maintenance dose of 70 mg per kg if emesis occurs within 1 hour of administration of the dose. And as many of us know, PO NAC has a rotten egg odor and taste, which not surprisingly is poorly tolerated by patients. So clinical studies have shown better outcomes with IV administration of N-acetylcysteine, which is kind of not surprising. So I also just want to mention that these maintenance doses can be continued after these, the 72 or the 21-hour regimen if a patient is still at risk for liver toxicity. So it's normal that if you recheck these acetaminophen levels, the levels might be low or normal, but the LFTs might still be rising because this liver necrosis that occurs does not happen immediately. It does take time for the liver necrosis to happen, and then the LFTs to rise as appropriate can take around like 18 to 72 hours post an overdose. So it's common to not see a rise in these LFTs. So if you do see that the acetaminophen levels are normalized, but the LFTs are still rising, you can still give another dose of the N-acetylcysteine to prevent hepatotoxicity. So next we're going to move on to opioids. So prescription opioids are used to treat moderate to severe pain, but they are associated with serious risks and side effects. So opioids act via the endogenous opioid system by acting as potent agonists to the mu receptor. This results in a complex cascade of intracellular signals, resulting in dopamine release, blockade of pain signals, and a sensation of euphoria, which is commonly why these drugs are abused. The opioid epidemic has evolved rapidly in recent years, and almost 70% of the drug overdose deaths in 2018 involved an opioid. So in overdose, there is an excessive effect on the portion of the brain regulating the respiratory rate, resulting in respiratory depression and eventual death. So symptoms of opioid toxicity include the respiratory depression, confusion, pinpoint pupils, and pale and cold skin. So if a patient is presenting unconscious and has these kinds of symptoms, you might lean towards suspecting an opioid overdose. So naloxone is the opioid antidote. It acts as a pure competitive opioid antagonist with a high affinity for the mu opioid receptor, allowing for a reversal of the effects of opioids. So naloxone can be given IV as well as intranasally. Dosing of naloxone is titrated to effect. So the goal of administration of naloxone is to increase the patient's respiratory drive to allow for adequate spontaneous respiration and oxygenation. So in most cases of overdose, the reversal is observable in a matter of minutes. And you don't want to initiate full reversal because this can result in withdrawal and can include combative or aggressive behavior, or you can even precipitate like with further withdrawal symptoms like such as seizures in a patient that is severely dependent on opioids. So you just want to titrate the naloxone to the dose until they're spontaneously breathing to prevent that respiratory depression. So the starting dose of naloxone is usually between 0.4 to 2 milligrams. And since this naloxone does have such a short half-life, it can be administered every 2 to 3 minutes. And since its duration is, since the duration of action is shorter than that of opioids, repeat doses are typically needed. So you can expect to give repeat doses of naloxone. And then I have here the intranasal dosing as a 4 milligram, a 1 spray as a single dose. And I just want to point out as well that in some cases, like such as an overdose of a long-acting opioid, such as methadone, intravenous drips of naloxone may be useful as well. So just keep your eye out on that for if you ever see like a naloxone drip. So next we have benzodiazepines. So benzodiazepines are used to treat anxiety, seizures, withdrawal states, insomnia, and agitation. Benzodiazepines exert their effect via modulation of the gamma-aminobutyric acid A, or the GABA-A receptor, which is the primary inhibitory neurotransmitter in the central nervous system. Benzodiazepine overdose alone is relatively unlikely to cause respiratory compromise. However, when it's taken with co-ingestants such as ethanol or other medications, respiratory depression can occur. So some symptoms of benzodiazepine overdose include slurred speech, ataxia, and altered mental status. So flumazenil is the reversal agent for benzodiazepine overdose. Flumazenil acts via competitive inhibition of benzodiazepine receptors that can reverse the benzodiazepine-induced sedation. So flumazenil is not recommended for routine reversal of benzodiazepine overdose. So if a patient who has a chronic benzodiazepine dependence is given flumazenil, acute withdrawal syndromes can occur, which can be life-threatening, and lowering that seizure threshold. So essentially, the biggest risk here is that if you're giving the reversal agent for benzodiazepine and a patient has a seizure, and our treatment for acute seizures is a benzodiazepine. So essentially you're kind of eliminating your treatment and you can't be able to really break that seizure quickly. So that's kind of the big risk of giving this drug. So the role of flumazenil typically is in like a pediatric population with an accidental ingestion or the acute reversal of a procedural oversedation. So if a patient was overly sedated unintentionally, you can use flumazenil to reverse. So basically the decision to administer this reversal agent, it depends on like a risk versus benefit analysis. And I included here the dosing just for your reference as well. So next we have digoxin. So digoxin is a cardiac glycoside that acts on the sodium-potassium ATPase pump of the myocyte. It reversibly inhibits the ATPase pump, resulting in increased influx of ions, which assists with myocyte contractility. So this inhibition of the sodium-potassium ATPase pump leads to an increase in extracellular potassium, making hyperkalemia an important marker in digoxin toxicity. And this hyperkalemia may precipitate into cardiac arrhythmias, another key marker of digoxin toxicity. So digoxin is a narrow therapeutic window drug with serum concentrations in the range of 0.5 to 0.9 nanograms per ml. And there are certain risk factors that increase the risk of digoxin toxicity, such as renal insufficiency because digoxin is renally excreted, electrolyte abnormalities that may also increase the patient's susceptibility to the toxic effects of digoxin include hypokalemia, hypomagnesemia, and hypercalcemia. So important to monitor electrolytes when a patient is on digoxin, and patients of advanced age are also more susceptible to the toxic effects of digoxin. So diagnosis of digoxin toxicity is primarily based on clinical presentation in the setting of suspected digoxin intoxication. So digoxin toxicity is more of like a chronic toxicity versus an acute. So patients that have been on it chronically and have developed renal insufficiency might be more at risk. So some symptoms of toxicity include anorexia, nausea, vomiting, and the key one here is also these visual disturbances. So patients will often report seeing like yellow-green halos in their vision. So the antidote for digoxin is Digifab or Digibind, which is digoxin immune fab. And basically how this works is that the Digifab provides antibodies specifically against the digoxin, and then the digoxin is going to bind preferentially to the antibody fragments rather than the receptors, so they can no longer bind to the receptors. So indications to administer Digifab include like acute ingestion, so an acute ingestion of greater than or equal to 10 milligrams of digoxin in adults, or greater than or equal to 4 milligrams in children. Also, an indication for Digifab is going to be an ingestion causing a steady state serum concentration greater than 10 nanograms per ml, or if a patient exhibits manifestations of life-threatening toxicity, which includes arrhythmias, progressive bradycardia, serum potassium greater than 5.5 milliequivalents per liter in adults, or greater than 6 milliequivalents per liter in children. And so the dosing of Digifab is pretty unique in that it does require like a formula. So if you know the amount of digoxin that was ingested, so you can find the dose of Digifab needed in number of vials by taking the total digoxin body load in milligrams, so how much digoxin the patient ingested, divided by 0.5 milligrams. And this 0.5 milligrams comes from that each vial of Digifab will bind approximately 0.5 milligrams of digoxin. So that's kind of where that 0.5 comes from. And it's important to note that when you are calculating the total digoxin body load, that you want to take into consideration the bioavailability of the tablet. So I included that here for your reference. And if you don't remember the formula, the package insert and LexiComp do have charts that you can access for reference if this ever does come up. So if you don't know how much the patient ingested, but you do have a steady state serum concentration, you can also calculate the number of vials that you would need to reverse digoxin based on, you take the serum digoxin concentration in nanograms per ml times the weight of the patient divided by 100. So this kind of chart also lays that out here for you. And here quickly, I just want to talk about the difference between free digoxin levels and total digoxin levels. So total digoxin levels after you give Digifab or Digibind are actually going to rise after you administer this. And that's essentially because it's going to take all the digoxin that was on the receptors and pull them off and attach it to the immune fab. So basically your total digoxin level is going to be higher than original. So if you ever get a question, you don't need another dose of the Digifab. That's basically how it works. So the digoxin is not going to be able to bind to the receptor. So here, free digoxin levels are going to be more useful to monitor because that's going to show you what's actually free and available to bind to receptors. So next we have sulfonylureas. So sulfonylureas are used for treatment of type 2 diabetes. And sulfonylureas act by stimulating insulin release from the pancreatic beta cells. So some examples include glipizide, glimepiride, and glyburide. So sulfonylureas are particularly dangerous because of their prolonged duration and increased elimination half-life during overdose. So the hypoglycemia that's produced from sulfonylurea overdose is typically refractory to IV dextrose. So even small doses may produce deadly effects in a toddler, so even 1 or 2 tablets, just because of this prolonged hypoglycemia that's refractory to IV dextrose. So symptoms of sulfonylurea overdose are similar to those of hypoglycemia and include dizziness, confusion, sweating, palpitations, and sometimes a patient may present with seizures as well. So like I mentioned, in the initial presentation of sulfonylurea overdose, you're going to give dextrose. However, it's going to be refractory to this IV dextrose, and therefore you might warrant the use of octreotide. So how octreotide works, it's basically a long-acting synthetic somatostatin analog that binds to the somatostatin 2 receptors on the pancreatic beta cells, and therefore are going to block insulin secretion. So although this is not a direct antidote to octreotide, it is used in toxicities because it will kind of counteract the effects of the sulfonylurea to prevent the hypoglycemia. So it's going to prevent further insulin from being secreted. And so octreotide can be administered sub-Q or IV, and the sub-Q route is preferred. And then I just include the dosing here as well. And then lastly, we have salicylate toxicity. So salicylates are another widely available over-the-counter medication. that are commonly used for their analgesic, antipyretic, and antithrombotic properties. Some examples of salicylates include aspirin, bismuth subsalicylate, as well as many topical products that include methyl salicylate, like Icy Hot, or like various oils actually will contain salicylates. So salicylate toxicity causes a variety of metabolic disorders. So salicylates are weak acids, and this is going to contribute to its mechanism of toxicity. So basically how the toxicity occurs is in phases. So in the first phase, you're going to see a respiratory alkalosis. So this respiratory alkalosis is due to the increased serum concentrations directly activating the respiratory center of the medulla, and this is going to result in hyperventilation. So that's the first phase. And then in the second phase, there's going to be renal compensation for this hyperventilation and this respiratory alkalosis. So it's going to create a mixed acid-base disorder with a metabolic acidosis. And here you'll see increased lactic acid production, and you'll also see a urine pH drop to around less than 6. And then in the last phase, or the third phase, the patient's going to be so fatigued and no longer able to compensate via this hyperventilation. And then in this stage, you'll see hemodynamic instability and end organ damage. So basically for treatment of salicylate toxicity, you just want to prevent patients from getting into this third phase, because this is where irreversible damage is going to happen. So the treatment for salicylate toxicity is sodium bicarbonate. And again, this is not like a reversal agent, but it's used rather to correct this metabolic acidosis that's occurring. So the goal of administration of sodium bicarbonate is to alkalinize the urine. So like I mentioned, the urine pH is going to drop to less than 6. But when you give sodium bicarb, you kind of want to titrate it to a goal pH of a goal urine pH of around 7.5 to 8. So you want to increase that. And so by alkalinizing the urine, you're going to increase the ionization of these weak acids, so the salicylates, making them more water soluble and more readily eliminated by the kidneys. So in addition to administering the sodium bicarb, you also want to make sure that the patient's adequately hydrated and giving enough fluids so that they're able to eliminate the salicylates in the urine. And some patients that present with salicylate toxicity may warrant emergent hemodialysis. So some indications for hemodialysis include if a patient comes in with chronic salicylate toxicity and they have a serum salicylate concentration greater than or equal to 40 milligrams per deciliter, or if a patient comes in with acute salicylate toxicity and has a serum concentration of greater than 100 milligrams per deciliter, because the end organ damage is so severe, they might warrant hemodialysis to prevent that end organ damage. So to wrap things up here, so now that we talked about a lot of the different drug overdoses and the various reversal agents and treatments, I just wanted to wrap up with some important counseling points. So as pharmacists, we are the dispensers of medications, and patients can greatly benefit from counseling on medications to be aware of and identifying signs and symptoms of toxicity and what to do in times of overdose. So I just included here some counseling points to prevent these accidental ingestions from happening. So locking medications in their original packaging where children cannot reach them is important. Making sure patients know to carefully read and follow label directions of all medications. Keep medications in vials with child-resistant caps, making sure they're kept in their original containers. It's also important to avoid calling medication candy to children, because they might be more likely to use that exploratory behavior and associate candy with medicine, and some of these medications can be very toxic to children. And it's also important to safely dispose of any unused, unneeded, or expired prescription drugs, as well as over-the-counter drugs, vitamins, and supplements. So some safe ways to dispose of medications. So you can mix medications with coffee grounds or kitty litter and throw them away. There are local take-back programs, and as well as national drug take-back events, which I actually think the national drug take-back event happened last weekend, the 24th. So important to make sure that you're aware of those and counsel patients if those come up. And then local drop boxes. So local drop boxes are usually at police precincts, or some pharmacies may have them as well. Okay, so in summary, activated charcoal can be considered first line as a gastrointestinal decontamination of choice, and it's used for patients within 1 hour of ingestion. The other methods of gastrointestinal decontaminations have limited use, and the risks might outweigh the benefits. Identifying common symptoms of toxicity and knowing what antidotes are available can be life-saving. And counseling patients on safe medication handling can decrease rates of accidental overdose. Anybody have any questions? So we can get into the post-assessment questions if no one has any questions. So for the first post-assessment question, under which of the following situations would activated charcoal not be appropriate? A, ingestion of lithium, B, ingestion of aspirin, C, ingestion of acetaminophen, or D, ingestion of carbamazepine? Okay, A is the answer. So lithium, so that goes back to that PHAILS, P-H-A-I-L-S mnemonic, in which medications that are not absorbed by activated charcoal. So next we have a 32-year-old patient is noted to be overly sedated after administration of midazolam for a procedure. Which antidote would be the most appropriate to administer to this patient? Yes, B. So B, flumazenil. So this is a benzodiazepine overdose. So GB, question 3, GB is a 68-year-old patient that reports feelings of appetite loss, loss of interest in his usual activities, and reports seeing yellow-green halos around lights. His physician is suspecting a medication toxicity and would like to know which medication on the patient's medication list is the most likely cause of his symptoms. So we have lisinopril, digoxin, amlodipine, or atorvastatin. Yes, digoxin. So that's going to be those green, yellow-green halos. Okay, so true or false? The Rumac-Matthew nomogram can be applied to ingestions less than 4 hours old. False, correct. Yes, so you want to use it in 4 hours or greater. So lastly, which of the following counseling points is important to discuss with patients to minimize the risk of accidental drug ingestion? A, store medications in their original packaging. B, store medications in locked cabinets out of sight and reach of children. C, always ensure that you are aware of which medication you are taking and the appropriate dose that is described on the label. Or D, all of the above. D, yes, all of the above. Okay, so those are the questions. Does anybody have any final questions before I wrap up and get the code? I just have to stop recording 1 second. Sorry.